Clark State Community College. Danny is viewed around the State House as a strong researcher and policy analyst who is thorough and detailed in his work. Again, I'm going to remind everybody we want to be as interactive as possible today. I'm sure Danny's presentation is going to spark a lot of conversation. So please be sure to use the chat box to network, ask questions, and note observations. We want to hear from you. And just remember to select everyone in that when you're making a chat comment so that everyone, not just the hosts and panelists, can see you. Ohio AAP staff and speakers are monitoring the chat box and will do our best to answer questions live. And we will have a few minutes for staff to read questions at the close of the session. Any questions that we do not get to answer will be shared in a Q&A document following the conference. This is always a fantastic talk. Every year we say, boy, it's been a crazy year. And I think this year probably topped all of them. So Danny, I'm going to turn it over to you and let you give us an update on advocacy. Thanks for joining us.
Well, good afternoon, everyone. It's been a year. Again, Danny Hurley, Vice President, Capital Consulting Group. Great to be with you all. One fact I always like to point out is our firm was founded in 1994, not by me, but the Ohio chapter of AAP was actually the very first client our firm signed. So I always like to say, we've been with you all since we started, and really since the first clients I met with when I started in 2012 was Melissa and Dr. Cotton, and it's just been a really great journey. You can go to the next slide, please. Or do I have control? Oh, I have control. Nice. So again, Danny Hurley, Capital Consulting Group. We are in the 134th General Assembly. We've been in that General Assembly for just about 10 months now. Some of the things that have happened, and we're going to delve into some of these in a little more detail, but just to kind of level set, we passed the state operating budget, which had a number of good things and maybe one or two not so good things. There's been, as you all know from media coverage, a significant amount of time spent on vaccines, COVID-19, and issues like that, which again, we have a whole slide dedicated to that, so don't worry. There's, politically, there's a lot of division both between the governor and the legislature, even though they're all members of the same party. And a big chunk of that is because of COVID-19 and the governor's handling of the pandemic really throughout 2020 and now the legislative backlash to that. We do have the Dicenial Census is now complete, so we have new legislative maps for state house races that'll take effect for next year's election, and then we should be seeing congressional maps coming. Obviously, this is a once every 10 years process, and it can result in some changes to the political makeup of the General Assembly. That can be good or bad, but we'll talk a little more about that as well. Those of you that have been on my calls or my presentations before know we have this major reform underway within the Ohio Department of Medicaid. It is a complete redesign of the managed care program, which serves well over 90% of Medicaid enrollees in Ohio. About 3 million Ohioans get their coverage from Medicaid, so and the majority of that are children. So this is a huge shift in how Medicaid is going to reimburse and how providers are going to navigate that system. So we'll talk more about that, but this is a very big lift that within the next 7 months is going to be finalized and turned on. So we're getting really close to the end of this multi-year process. A number of states have introduced or pursued legalization of adult use cannabis. There is a ballot initiative currently underway in Ohio to first place this issue before the General Assembly next year and then potentially put it on the ballot next fall. We also expect some legislation to be introduced by a few legislative Republicans in the next few weeks. So, I know Ohio is still pretty new into the medical marijuana space, but we are going to see a push to legalize all cannabis for adults 21 and over. On the election front, we are really looking at 2022. The governor and Secretary of State LaRose both have primary challengers. Several state lawmakers do as well. And a lot of these challengers are kind of coming from the right flank. The governor actually picked up 2 challengers that are both being very critical of the governor's handling of the COVID pandemic. So really, the takeaway from all this is, COVID has really changed our state politics very quickly. And to Dr. Peltier's introductory comment, it's definitely made things much more interesting, I'll say, at the State House. So with that, next slide, please. Because I don't have the ability to control them. Just here's what we've done so far. So again, we're almost 11 months into this General Assembly. The big sort of high-profile issue was House Bill 110, the state operating budget. Overall, it had a lot of good things for us. Those of you that recall, when Governor DeWine came into office, his first operating budget increased various funding for programs for children's health, about more than $1 billion, a significant investment in telehealth and behavioral health services and service delivery in schools and Medicaid funding and all these programs. So, $1 billion in new funding flowing out to the community to help take care of kiddos, and the funding was basically continued, and that in and of itself, in this political climate, was a win. We are going to see in the next 3 years, Ohio is the only state that does not license hospitals. We are actually going to see a hospital licensure framework developed by the Ohio Department of Health. This will be pretty modest in terms of its regulatory impact, but it is something those of you that are hospital-based might be hearing about in the next few months and years. Major overhaul of Ohio's school funding formula. Certainly when it comes to academic performance and readiness, this is important. Also, the school funding formula does have a lot of money that's geared towards whether it's taking care of children with developmental issues, healthcare delivery in schools, and things like that, addressing social determinants. So there's a lot in that school funding formula that can impact the kiddos that you're taking care of. We did see the Children with Medical Handicaps program under the Department of Health eligibility was increased to age 23. There's actually a standalone bill to make this expansion permanent and take coverage all the way to age 26. The problem with what's in the budget is if we do nothing in the next budget or we don't pass a standalone bill, that expanded eligibility goes away. And for those kids that are, getting to that age of maybe losing the parents' health insurance, these are kids with a lot of health needs, and this program is very impactful to them. In the terms of the state budget, it's a very small amount of money, but it's hugely impactful to these families. We saw some really positive changes to how we're going to handle newborn screening going forward. The first is adding two screenings that have been approved by the that are on the RUSP currently. That's spinal muscular atrophy and adrenoleukodystrophy. I think I said that right. So we have two new screenings that are going to be coming online at the Department of Health for the newborn panel. But then there's some language in there now that says within 18 months of any future screenings being added to RUSP, that the department must implement them. So those of you that follow this know, there have been, I guess, a little bit of a delay in SMA getting added specifically. Some of that was due to COVID and the need for the state lab to convert to doing COVID tests early on. But obviously these screenings are important. They're recommended. We want to make sure they're being done. And so now we have a little bit of a stick going forward that will hopefully keep make sure that any future newborn screenings are added in a timely manner to the state panel. We did see the controversial this conscience clause language added. My understanding is ACLU and some other organizations are contemplating a lawsuit. Just so everyone understands, this language basically says any provider or healthcare facility can refuse care to a patient if it violates the provider or the facility's conscience or religious beliefs. The bills, the advocate community very concerned about this bill and what it might mean. It certainly, we don't want to create a situation where we're discouraging people from coming to the hospital or coming to see a provider because they fear, this conscience clause language. Ironically, I guess this conscience clause was actually cited. I can't remember if it was Cincinnati Children's or UC Health, but one of the Cincinnati area hospitals actually got sued because they had a patient who was COVID positive and wanted to be treated with ivermectin, and the provider refused, citing the conscience clause language that was recently enacted, and actually prevailed in that. So I think that was a really that it was probably the only good example of the use of the conscience clause we're going to get. And I think it is something that is probably I think the lawsuit, if it's not been filed, is going to be filed in the very near future. Lastly, no major Medicaid changes. If you have been on these calls a while and in previous budgets, we talked a lot about Medicaid and Medicaid cuts and Medicaid expansion and all these things. That a lot of that has died down, and we're actually there was not a lot in this budget that that was in the final version of the budget that we had to deal with on the Medicaid front. Also, we've been talking a ton about the COVID-19 pandemic. Early on in this General Assembly, lawmakers did pass legislation, Senate Bill 22, that really did two things. One is it restricted some of the powers of state and local health departments. This is specifically around quarantine orders for individuals who have not had an exposure or not positive for COVID-19. This was meant to go after some of those, universal masking orders and stay-at-home orders. The other thing it did is it allowed the General Assembly, through a concurrent resolution, to rescind any emergency declaration or public health order issued by the governor or the State Department of Health. This took effect in the end of June, and right before then, the governor actually he lifted the emergency declaration of the COVID-19 pandemic and rescinded all the existing state health orders. Now, if you recall back in June, cases were really low, and then we had the Delta variant surge in late summer. But actually, Ohio did not return to a state of emergency, and no statewide orders were issued. And a big reason for that is the enactment of Senate Bill 22 and the idea that if the governor tried to say mandate masks in schools statewide, the General Assembly would have quickly overturned that, and we'd be in a very difficult situation. So Senate Bill 22 definitely had a chilling effect on what the DeWine administration, and to a degree what on some local health departments have done to combat the COVID-19 pandemic. And that probably is a contributing factor in why we did see a surge of cases in July and August and September that are just now starting to turn the corner and come down, is we were not able to have the same statewide orders we had in the previous General Assembly or the previous year. There's been a lot on anti-vaccine. We're going to talk about this more. The one bill that actually did get passed, and it initially had a lot of controversy, but it was not actually that impactful bill, is House Bill 244. This was a pretty benign bill. A last-minute amendment was added to it that said nobody could mandate a vaccine that had not been approved by the FDA. And this was really targeting the COVID vaccine, but it was passed about 3 weeks before the FDA approved the COVID vaccine, formally took it off of emergency use. So that at that point rendered this bill moot. So it was a bill that was more of a symbolic victory for legislators, but it really did not have an impact on the actual ability of provider or hospitals and employers to require employees or clinicians to be vaccinated against COVID-19. Just highlighting a couple of bills that have been enacted so far this year. The first, so licensure compacts, there's actually been 5 of these bills passed. The one that I would say you all would care about is the medical licensure compact. And what this is, I think a total of 30 or 31 states now are members of the compact. Ohio will officially join in the next 12 months. And basically, if you are in a compact state, you can go, or like Ohio, you can go to any other compact state and get an expedited licensure. And this is really impactful for 2 reasons. One is for telehealth and your ability to deliver your services to patients in a different state. The other is for those of you that might be practicing maybe in Cincinnati or up in Akron or Youngstown or Toledo, where you're right on the border, and you probably have patients or even sites of care across the border. This will hopefully make things easier for you in terms of getting licensure in those other states. So it's really it's a workforce component or workforce bill. We supported the bill as did all other physician groups. And those of you that have interest in practicing in other compact states, once we're in, it'll hopefully make life easier for you in terms of maintaining your licensure. The other bill on the injury prevention front, House Bill 9. This is a bill that has been around for a few general assemblies, but we finally got it across the finish line. And what it effectively does is prohibits the sale of any over-the-counter drugs that contains dextromethorphan to minors. A lot of the larger pharmacies already have a policy like this in place. So if you try to buy Robitussin or something, it actually the cash register or the cashier will ask to see an ID. But this is really targeting some of the smaller pharmacies that maybe don't have these protocols in place. So very good bill, and happy to see that get across the finish line. Next slide, please. All right, so immunization issues. historically, if you go back like 5 years, we were in a very different position on vaccines. We had just passed legislation to restore the vaccine requirement for childcare facilities. We had gotten the meningitis vaccine added to the list of school entry vaccines with no opponents. And we had just had a bill introduced that would have really tightened up the way we process exemptions. Sort of, we call it the Michigan model, basically trying to require parents to seek a provider signature for any opt-outs. And then fast forward 5 years, we had the anti-vaccine community really come to life in Ohio, and then we had the COVID-19 pandemic, and now we're in a very different climate than we were 5 years ago or 6 years ago when we were passing bills unanimously with no opposition. That implemented vaccine mandates. I mean, with the medical, religious, and philosophical exemptions, but still, the idea that we were enacting vaccine mandates with no opposition seems crazy when you look at what's going on with the General Assembly today. So this has really become very toxic. There are some lawmakers that have actually had security details because they received death threats from anti-vaccine activists. You've seen protests at legislators' homes in their neighborhoods. This all kind of started with Dr. Amy Acton, the former state health director, who just a few blocks from where I'm sitting right now here in Bexley, there were armed protesters at her house, and it was really, the tactics of this community have continued to kind of progress into a very dark place. Now, from a legislative standpoint, none of these bills have really been able to get enough support with the Republican majority to pass. So, we've not actually taken a loss. We're not able to really advance any more pro-vaccine bills, but we find ourselves more and more playing defense and really being subjected to some pretty hostile tactics on the part of the anti-vaccine groups. The bill that's probably gotten the most attention is House Bill 248. And this was introduced by State Representative Jennifer Gross, who's actually a nurse practitioner from Southwest Ohio. And this bill applies to all vaccines. So it is not just COVID-19, it is any vaccine. It is a very broad prohibition on any vaccine mandates, as well as several other provisions that would really have a chilling effect on Ohio's vaccination rates. It does not repeal the vaccine requirements for school and childcare, but it would require schools to basically notify parents in big bold letters of their opt-outs, of their exemptions. And so it's just across the board is a very, very problematic bill. It had hours upon hours of committee hearings and testimony. Some of the testimony was a little more colorful and attracted some national attention for people, sticking keys to their arms and making outlandish statements about 5G towers and how they communicate with COVID vaccines and all these kind of outlandish things. So that bill is effectively dead in the House Health Committee. Towards the end of the debate around House Bill 248, State Representatives Rick Carfagna and Bill Seitz, who are both in House leadership, at the direction of the Speaker, introduced House Bill 435. And this was meant to be a more, a more rational. It was not a bill that we, on our side would support or be okay with, but it was meant to try to be a bill that could get 50 votes in the House Majority Caucus. But it fell short. There were literally no proponents of this bill. We opposed it. The anti-vaccine groups opposed it, and it effectively died as well. So a couple weeks back, the Speaker basically put out a statement saying we are pressing pause on vaccine bills in general. We just cannot get consensus, and we've got to deal with other bills. And part of why that was such an issue is there were a handful of legislators that were really pushing these anti-vaccine bills to the point where they were refusing to vote on any other bills unrelated to vaccines that were going to be in the House, on the House floor, until they got a vote on the vaccine bill. So, the Speaker really tried to appease them, but there's just not a consensus. So the way to sort of wrap that up is to say, I don't think we're going to have to scramble too much more on vaccine issues for now. I do think that there are some things that could happen that might reignite the debate. With the COVID vaccine being approved for children ages 5 to 12 imminently, I do know some school districts are seeking legal opinions on whether or not they can actually mandate it for the students. If that were to take place, that might get legislators fired up again. So for now the issue has kind of cooled, but there certainly are some things that can reignite this issue. Outside of the vaccine issues, there's a bills pending dealing with vaccine passports. There are bills pending dealing with masks in schools. None of these bills really seem to be gaining traction. I know legislators were pretty happy with the new COVID-19 quarantine guidelines, I should say rules in their guidelines that came out, as well as just the fact that we are seeing declining caseloads, and maybe we're reaching a point we might be coming out of the pandemic here in the not too distant future. So I do think the issue is sort of quiet, sort of bubbling below the surface, and we hope it stays that way. Next slide, please. And so another area where we have very recently seen some bills kind of heat up is in the space of transgender and gender affirming medicine. For a while now, we've had what they call the Save Women's Sports Act, House Bill 61 and Senate Bill 132. These are bills that would prohibit transgender females from participating in women's sports at the recreational, high school, and intercollegiate level in Ohio. Certainly issue we've seen in other states. The bills have had a couple hearings, but are not moving with any great urgency. But it is something where, those of you that maybe work with that population know, even just the mere existence of these bills can really, sort of frighten or cause harm to these patients. We do have on the sort of the flip side, though, we do have two companion bills that have bipartisan sponsorship. House Bill 208 and Senate Bill 119 that would add gender identity and sexual orientation to the state's civil rights laws. So those bills, again, not moving too quickly, but bills that I guess sort of we have a good and a bad. And then very recently, House Bill 454 was introduced. So this was 2 weeks ago now, and this bill has been introduced in the past few general assemblies, but it basically prohibits most or pretty much all of what we consider, medicine in the gender affirming space. So any kind of hormone therapy, gender reassignment, anything else on minors. It would effectively put your license at risk. Also, the bill says any hospital that provides these services would lose their Medicaid funding. So obviously for the children's hospitals that have these different kind of gender affirming clinics, this is a major issue. The bill, again, just introduced. There is a large coalition forming to oppose it. Ohio AAP will be involved, as will many other physician groups, children's hospitals, ACLU, Equality Ohio. So we're going to have a very broad coalition of both healthcare and community activists that are going to be opposing this. And the early indication is this bill is not going to move with any urgency. I doubt we'll even see the bill up for a committee hearing before the end of the year. So we just really want to be, vigilant on this. AAP National's given us some great resources. I know we've got a lot of great advocates within the Ohio AAP. So this is one, again, its mere existence. I actually was speaking to some of the clinicians at the Center for Gender Affirming Medicine at Aprn Children's earlier today, and they've already had parents asking them about this bill. And that to me is really, that's a really sort of scary or frustrating position, is even a bill that isn't, in any kind of imminent danger of moving has already sort of caused harm and caused panic among these parents. So that's where we're at on these issues. The coalition. So that's really all I would say. Just that, I guess, lastly, these bills, if you look at the sponsors of House Bill 454, it's pretty much all the legislators that are co-sponsors of House Bill 248. So you have, so apologies for the dogs barking, by the way. You have, kind of the anti-vaccine folks are also the folks that are pushing the transgender stuff, also the folks pushing the anti-critical race theory. So it's kind of a coalition, if you will, sort of an informal freedom caucus of legislators here in the House that are really advancing these bills and creating lots of consternation. Next slide, please. All right. So, moving on to maybe less contentious policy areas, kind of our practice of medicine prescribing bills. I'll just walk through these very quickly. House Bill 160, this is the latest attempt at healthcare price transparency. The very quick history here is, this was enacted several years ago. It was actually part of a court challenge. The AAP, Ohio joined hospitals and other groups the law was overturned, and then we've had just attempts since then legislatively to try to enact this. Obviously, we're not against price transparency. The problem is these bills create an unworkable or, frankly, very costly requirement mandate on providers to provide pricing estimates to patients. And that's really where we've come from. I think probably most of you, if you were asked by a patient, hey, what's this going to cost? You could probably give them through your staff some kind of estimate that factors in insurance reimbursement, things like that. But the idea to mandate it in a very aggressive way is just really, really difficult. House Bill 122, probably one of the very few silver linings of the COVID-19 pandemic is we really got to run with telehealth and deploy it in very broad ways. House Bill 122 seeks to codify the expansion of telehealth services under Medicaid, which historically physicians have had pretty good access to telehealth under Medicaid, but it was broadened at the start of the pandemic for maybe some of the other providers, not necessarily physicians, but other providers who were left out. But then also adds a telehealth mandate for some of the state regulated health insurance plans. So I would not say if this bill passes, it's going to be hugely impactful, but it at least sort of keeps us moving in that direction of keeping telehealth as a tool in the toolbox. Of course, House Bill 221, it wouldn't be the Ohio General Assembly without an APRN independent practice bill. So this is sponsored by State Representatives Tom Brinkman and Jennifer Gross. This one is a little bit different than true independent practice. It actually creates a pathway to practice. So you would be, as an APRN, you would have to have 12 months or 2,000 hours of supervised practice. At the conclusion of that, you would then be able to apply to get your independent certification. For this first class of APRN, supervised practice must be with a physician. But after that, supervised practice can be with a physician or an APRN that has achieved their independent status. So you basically have a scenario where the APRNs can kind of sort of self-propagate in the independent space. So those have been beaten back pretty heavily. Legislators generally wary on the scope of practice bills, but it's an issue that's out there. And those of you that have followed this issue know the APRNs are very, very organized and very aggressive. So this is not an issue we ever want to sleep on. We always want to have our talking points and our messaging ready to go, because this is one that could easily go from being kind of dormant to moving. House Bill 402. So this is a bill that creates sort of a regulatory framework for midwives. And there's some language in the bill. I mean, we're sort of working this in tandem with the American College of Obstetrics and Gynecology. There's some language in the bill around midwives providing newborn care. And this bill is not moving with any urgency, but I think we wanted to understand more what to do for the babies born. The whole piece of this around the delivery, that's more ACOG's concern, but we just want to understand what is it, because that just sort of raises a red flag for us. Additionally, on the prescribing front, we have some bills. House Bill 135. This prohibits a practice known as copay accumulators, which those of you that work with patients with rare diseases are probably familiar with that term. But basically, patients, say with eating disorder or epilepsy or another condition that requires costly medication, they often will receive copay assistance from the pharmaceutical manufacturer or from another group. Health plans have started taking that copay assistance, allowing it to be used at the pharmacy counter, but then not applying that assistance to the patient's deductible. So what happens is, after that patient exhausts the copay assistance and they go in thinking they've also hit their deductible, they now have to shell out $5,000 to get their deductible. And many of these medications are several $1,000s a month. So this seeks to prohibit that practice. And we would hope to see this get done. It's got a lot of support in the rare disease space, which we do some work with as well with other clients. House Bill 153, sponsored by State Representative Liston and Carruthers. Of course, Dr. Liston, you all know well, is a pediatrician in the General Assembly. This would prohibit any kind of mid-plan year changes to drug coverage. This is really a leftover the step therapy reform bill we got done a few years back. And really what we're trying to do is if a lot of times if a drug manufacturer changes the rebate they're giving a health plan, that health plan might reclassify the drug, take it off preferred status, or put it on a lower tier, and that can disrupt patient access. We understand that health plans have to, and PBMs have to kind of ensure that they're balanced, but we don't really think it's a fair practice to make those kinds of changes during a plan year, because a lot of patients, again, with maybe with kids with rare disease, they might select their health plan based on the availability of a certain drug for a specific condition. So this, again, is really just aimed at ensuring patient access to necessary drugs. Both of those bills, 135, 153, are pending in House committee, and they have some opposition from the business community. So we are it's a heavy lift on those. But like I said, this is one the rare disease community and patient advocacy community is very passionate about. House Bill 193, kind of a minor bill, I think. It's already passed the House and the Senate, but basically it says you must use an electronic prescribing system if you're prescribing a Schedule II narcotic, unless you have a power outage or a system issue. I think pretty much everyone's using e-prescribing systems, and if you do have some type of IT issue, the bill contemplates that. So pretty minor bill, not one that a lot of folks have really weighed in on. So I'll leave it at that. Next slide, please. All right, injury prevention. And I saw a few comments in the chat about this. So we will start with fireworks. So this is something we, the AAP, along with other groups, have been very engaged in for the past few years. Ohio is one of only 4 states that does not allow consumer discharge of fireworks. We do allow you to purchase them. So back in 1983, we legalized the sale of fireworks in Ohio, but the compromise reached way back then was people have to basically take them out of state within 48 hours. So you can buy them here, but you have to take them out of state. Now, obviously, we know that most people who buy fireworks in Ohio do not take them out of state, and that about 90 to 95% of fireworks are discharged around the 4th of July. But we've always had this law in the books, and we've defended it on the grounds that we still have a sort of statewide proclamation or statement that fireworks are dangerous. They're prohibited because they're dangerous. And like speeding or drunk driving, we understand people are going to do it regardless of where the law is, but that doesn't mean we should ignore the law. Earlier this year, the legislature, the latest version of this, because it's been going on for several general assemblies, the latest version of this was Senate Bill 113, and it was passed, sent to the governor vetoed it at our request. So, the governor, big, children's initiatives priority. So we appreciated his veto. He had really his administration had 2 sets of concerns. One was around just discharge. The other was getting into some of the changes around the size of fireworks retail facilities. So this gets a little granular, but we're getting the fire code. Basically, if you have a fireworks retail outlet in the state of Ohio, it has to be limited to 5,000 square feet. Some of the larger retailers want to have bigger showrooms, and so they wanted to go up to 10,000 square feet. The compromise was 7,500 square feet with enhanced fire suppression. If you know your Ohio history, you know that back in 1997 in Scottstown, Ohio, down in Lawrence County, somebody into a fireworks retail lit firework, and 9 people were killed and 11 were injured. So we've had a really sort of tough history with fireworks in Ohio. Earlier this week, the Senate Public Safety and Veterans Committee reported out a version of House Bill 172 with some compromise language they had negotiated with the DeWine administration. Over the objections of us and our allies, they sent the bill to the House for concurrence. The House sent it to the governor's desk, and the governor has said publicly he is going to sign the bill next week. We are still advocating for a veto, though. The governor and his team have made it clear both publicly and privately that they are going to sign the bill. It is a pretty narrow. It's basically discharge of fireworks on specified days throughout the year. There's about 20 days, various holidays and weekends around certain holidays when you would allow people to discharge fireworks. Local communities will retain the ability to prohibit discharge. If your city or township and your leaders there don't want to allow fireworks discharge, they have that option. Two, I guess, let's assume the governor signs the bill. Two items of additional advocacy. One is the bill creates an advisory committee that will primarily look at fire code, but also look at other fireworks regulations. Ohio AAP was given a seat on that panel. It's primarily an industry panel, but we will have the ability to put a pediatrician on that panel to continue to press the injury prevention message. The other thing is, the state fire marshal who works under the Department of Commerce and has oversight of the fireworks industry, that individual is actually somewhat still concerned about the bill. And if you look at the language of the bill, has the ability to adopt some pretty strict rules on consumer discharge. So one thing we can do once the bill is in effect is with the state fire marshal to actually have really tight rules around how fireworks can be discharged, as well as maybe work on some educational outreach to communities with a goal of trying to discourage them from allowing fireworks discharge in general. So we fought this issue a long time. I think there's still work to be done, but I'm certainly, frustrated to see this bill advance. And I know we've had several, Dr. Denny, Dr. Gittleman, Dr. Cotton, and others who have spent a lot of time at the State House on this issue. And I think it's probably very frustrating. I can't imagine so, but it's probably very frustrating that those of you that be working in the emergency room and have taken care of a child injured by fireworks to now have this bill become effective is definitely frustrating. But I just want to say we fought the good fight on this one, and I think we've got a lot of work left to do. House Bill 159, this would prohibit minors from using consent. This is an issue that the dermatologists and the OSMA have really pushed. We've been involved in it. It's been an issue that's been around for probably 3 or 4 general assemblies now, and I just don't think that the legislature, the ideological majority of the legislature wants to place this kind of restriction on businesses. But it's out there, and when we have the NDBD test for this. House Bill 262. So this is a bill sponsored by 2 Democratic lawmakers. Probably not going to move, just given the subject matter. But it's interesting because it dovetails into an area that we've been advocating for a while, and that's promoting safe storage of firearms. So the bill does 2 things. One is it increases the penalties for negligent firearm storage. And I think there was just a story maybe last week or earlier this week in the paper. Child finds unsecured gun, shoots self. This would increase the penalties for that on the parent or the homeowner, but also would create a tax credit for storage devices. So we have spoken with Representatives Miranda and Kelly. The piece around increasing penalties is going to be a problem, but I actually have talked to some Republican lawmakers who like the idea of a tax credit for storage devices. There's actually not with sports, there's still pending actually all firearms state sales tax, but certainly, I think that the tax credit for storage devices is really intriguing. And then lastly, House Bill 285. So this is, you'll recall last year, the governor announced his intention to seek legislation to strengthen Ohio's distracted driving laws. And that includes expanding the definition of distracted driving and increasing penalties. This was introduced, it was not passed, it was then put into the budget and out of the budget, and now it's pending as House Bill 285. We've supported this bill. I know a lot of physician groups and patient advocates have supported it. The bill does have 2 good Republican sponsors, so I do think this bill has some legs behind it. So those of you that that are interested in this, we're involved in a large coalition, and we'll continue to press this. We're actually, excuse me, we're actually doing, as we speak, a whip count to see if we have the votes in the House to get the bill actually out of the House and into the Senate. So very exciting time on that issue. Next slide, please. So, Ohio Department of Medicaid. As we mentioned, when Governor DeWine first took office back in 2017, he instructed, 2019, he instructed the director of the Ohio Department of Medicaid, Maureen Corcoran, to basically rebid, or they call it reprocure, all of Ohio's Medicaid managed care contracts. And part of that was really a complete redesign of the managed care program. The last major update to managed care occurred in 2011. So it's it's been a pretty stale system. The launch date has been confirmed for July 1st of next year. There was a goal of getting it done in January. That's been pushed back. So we now know July 1st, 2022, they throw the switch on the new system. New managed care plans. So the plans you see there that are underlined, Molina, Buckeye, CareSource, and United, those are current plans serving the state. We now have 3 new plans coming in, Humana, AmeriHealth Caritas, and Anthem. These will be statewide. So you now have 7 statewide plans that patients can choose from. One of the features of the new Medicaid system will be centralized credentialing. So you will not have to go to every single one of these plans and be added to their panel. You'll be added to the Medicaid provider and you'll be eligible for all 7 plans. So right away, Medicaid has recognized that they need to make life easier. The one current MCO that is not part of the new system is Paramount, which is based in Northwest Ohio. Paramount actually filed a protest, and then when the protest was rejected, they are now in court litigating this. So Paramount actually bid to be a regional plan, not a statewide plan. And so I know a lot of providers in Northwest Ohio that have interacted with Paramount, since that's their geographic footprint, have been approached to advocate for Paramount being added. This is a court case now, but that question mark around Paramount and their status in Northwest Ohio is still out there. Additionally, we're going to have a single statewide pharmacy benefit manager. That's going to be a company called Gainwell Technologies, and they're also going to serve as the fiscal intermediary. So one of the, I think, really positive thing that's going to happen with the new managed care system in July of next year is we're going to have a standardized portal and process for claim submissions and for prior authorization submissions. So you will not have to file your claims with United or Humana or AmeriHealth or whoever. You will actually send all of your claims and your prior authorization requests, regardless of where the patient is enrolled, to Gainwell, and they will then take care of farming it out to the appropriate MCO and getting you your reimbursement. So, prior auth, same thing. There's going to be a standard process for every patient in Medicaid managed care, regardless of plan. So I do think that is going to make life administratively a lot easier, along with the centralized credentialing piece. Ohio Rise. So another program that I think is going to be really, really exciting is called Ohio Rise. It's going to be managed by Aetna, and it's basically a wraparound, if you will, service for children in Medicaid who have significant behavioral health needs. The department estimates around 50 to 60,000 Ohio children are going to be eligible for this. So it's supplemental to what is already offered under Medicaid. They actually just announced, and some of you that work in the behavioral health space may want to take a look at this, $25 million in transition grants. I know a lot of the children's hospitals are lining up to get a piece of that, but this is a major priority for the administration. This grew out of the administration's work around services for multi-system youth. And really for those children that have a significant behavioral health issue, this program will hopefully give them an escalated level of care in addition to what they're already receiving under Medicaid. So pay very close attention to Ohio Rise. This is a completely new component of the managed care system. This does not exist currently. Lastly, and kind of not as notable, would be there's going to be a pharmacy pricing and audit consultant. It's a firm called Myers and Stauffer. They're primarily going to monitor the single PBM, Gainwell Technologies. If you follow Ohio Medicaid closely, there have been a lot of issues around PBM conduct within Ohio, and specifically things like clawbacks and other behavior where they've siphoned off a lot of money that should have gone to pharmacies or to provide for patient care. So PBM, pharmacy, big issue within Medicaid. Since ODM started this process in 2019, Ohio AP has been very engaged in this. We've met with Medicaid several times. We've submitted several rounds of comments. And so some of the things you see is, I went back and was looking at some of our original comments. Some of the things we've seen around centralized credentialing, those were in our comments. We basically said, listen, you really need to, if you're going to have 6 or 7 managed care plans, we really need to have one point of entry. We cannot go to 7 different plans and have to constantly adjust based on who the patient's enrolled with. One of the major outstanding issues, though, and this one will you'll want to be aware of this. So we actually are about to enter open enrollment for Medicaid for the current plans. So this will just be open enrollment for January to June. Medicaid is then going to have another open enrollment period next spring that will be for the new managed care system that goes live on July 1st. One of the components of this is going to be how patients who do not select one of the 7 plans are assigned. Right now, CareSource holds about 80% of the managed care market in Ohio. Medicaid has an interest in sort of breaking that up. And so what we are going to see is a debate around, for after the open enrollment period closes, we're going to have a bunch of Medicaid enrollees that don't select a plan. Medicaid is going to deploy an algorithm that's going to assign those patients randomly to plans, and it's going to result in CareSource losing a big chunk of their market share. And that's very concerning, especially to legislators from the Miami Valley, because CareSource is a big employer there. So that's not an issue that we need to be directly involved in, but it is something that's going to potentially play out in the General Assembly, is how are patients going to be assigned under the new managed care system when they don't voluntarily select a plan. So I just want to make you all aware of that, because it is sort of a wrinkle that's out there. Lastly, Joint Medicaid Oversight Committee, they had a hearing this week continuing their look into pharmacy benefit manager conduct. And I just, this is an issue where Ohio has really been a leader, and a lot of other states have followed Ohio's lead in really trying to crack down on PBM conduct. So with that, I think the last slide is just questions. So jump to the last slide, please, or the next slide. Yes, questions. And I see we have a few. I don't know, Dr. Peltier, how you want me to go through that?
Yeah, why don't I kind of feed them to you, if that's okay?
Okay.
We're kind of monitoring the chat. But first, before we get to questions, obviously you saw the breadth of work that the chapter's working on, and just obviously lots of members have been very instrumental in this, but I especially have to thank 3 people. Obviously Danny for all of his work. Actually 4 people. I'm sorry, Danny, our chapter CEO Melissa Worvey Arnold, and our advocacy pillar co-chairs Bill Cotton and Dr. Sarah Denny, who really do the bulk of this work, and just amazing. It really has been a wild ride, and the chapter is grateful for all that you have done. So some of the questions have been answered during the chat, but I will say, so there was one, Danny, about telehealth coverage. One of our members had said that he got a notification from Paramount that telemed would no longer be fully covered after November 30th. Was wondering, does that mean it's still going to be partially covered? And do we know about other Medicaid or private insurance companies as far as telehealth payment?
So my understanding, so let's backtrack. So Ohio has a telehealth parity law on the books that broadly covers physician services. It's not reimbursement parity. So I want to stress it's coverage parity, not reimbursement parity. So you can be paid less, but it applies to the primarily the individual and small group plans that are regulated by the state. So that law is on the books. It's been in place and effective since January 1st of this year. Within Medicaid, there is a change coming to Medicaid's rules, effectively the emergency rules. Medicaid's normal telehealth rules broadly cover physician services, but one of the big changes is the initial patient visit is going to revert back to that having to be in person. That was one of the changes that was made at the start of the pandemic, is allowing initial patient visits to be done virtually before you could enter into that telehealth space. So that I would suspect if that Paramount is a Medicaid patient, I would expect that's what you're being told, is that initial patient visit needs to be in person. If you're hearing something else, let us know, because that does not jive with Medicaid's rules, or frankly their preference. I mean, they are supportive of providers using telehealth. So if it's something beyond that initial patient encounter, I want to explore that a bit more. But I'll leave it at that. So you should be able, if it's an established patient, you should be able to use telehealth if you choose to, especially if it's Medicaid.
Thanks, Danny. Dr. Dubey had a question about the Ohio RISE program and wondering what may happen to that. Could that program be at risk if a new governor is elected?
Theoretically, I mean, yes. it is not exist in statute. It is not a program that was created by legislation. So certainly the next governor and director of Department of Medicaid could come in and scrap the rules and cancel the contract with Aetna. That being said, I don't politically think anyone would do that. This program, even though it is a creation of the DeWine administration, has incredible support from a lot of advocates and folks in this space. So, yeah, anything that's not codified can be changed by the next administration. It would be a very cumbersome process. They could not just come in and pull the plug. I mean, you have rules that they would have to rescind. You have orders they'd have to repeal, and you have a contract you have to cancel. And I don't know all the terms of the Aetna contract, but you probably can't just come in and say, "Hey, Aetna, we don't need you anymore. Thanks." So it would not be an easy process. I think politically it would be a very bad process. But yes, I mean, Dr. Doobie raises a good point. That if a new governor comes in and wants to go a completely different direction, they could, and we would just have to deal with that issue if it comes up. But I would hope that any new governor would see that the work that's been put into this and frankly the impact that I believe it will have really necessitates its existence, regardless of administration. And the other thing I would add is if we were to get, let's say, a new governor comes in and we get the sense that they are going to do away with Ohio Rise, we could go to the legislature and have it codified. And that would be a way of removing the governor and the Department of Medicaid from that calculation. So, we certainly have some remedies if we get to that point, but I don't think we'll get to that point. If anything, I think we'll see the program evolve, and as we get feedback from its impact, we'll be able to make changes that will actually make the program better. But good question, Dr. Doobie.
Great, I'm scrolling, hang on one second. And Dr. Duffy commented that one hopes that Ohio Rise would reduce cost per patient, and some entity is gathering those data. And I do know, having sort of been on the board during when Governor DeWine came into office, I sort of know how closely that Danny and Melissa and our advocacy team works with the transition team and really advocates. So, if there is a new administration, I'm hopeful that we will be able to advocate our positions and hopefully continue that.
So that's the cost savings piece. I mean, this is always, when we're dealing with Medicaid, I mean, we always have to have that as part of our thought process is, will this save money? And sometimes things, we're spending more money because it's better for kids. But a lot of times, like I'll use lead screening as an example. Medicaid's paying more now and investing more in lead abatement, lead screenings. And maybe that might help us solve some of those downstream health issues. So I guess I think Dr. Duffy, I think the prediction that this will lower costs over the lifetime of some of these kids when they're on Medicaid, I think we would probably see that. In terms of tracking it, I don't know if Aetna will be doing that. That might be something. Those of you that are familiar with the Colleges of Medicine Government Resource Center here in Ohio, the GRC, they do a lot of data tracking on behalf of the state. They have a number of contracts with Medicaid. So I don't know if we're going to get that actual, almost like a longitudinal data set, but I think we'll get at a minimum some good studies, and I think we'll be able to generate after a few years some reasonable expectations of savings, of a cost avoided. But yeah, that's maybe something to ask Medicaid about, is how they plan to study it to determine its success and maybe avoiding some of those more serious health issues or inpatient stays down the road. So another good question, Dr. Duffy.
Great, thanks. So I think I know the answer to this, but I'm just going to clarify it. So although in July, when the new managed Medicaid plans come online and there will be centralized credentialing, I'm assuming that providers will still have to negotiate contracts separately with each plan. Is that correct?
Generally, yes.
That's what I thought.
Yes.
Great.
So
let me scroll again. Sorry, I was looking for questions. Here we go. Okay, so not so much really a question, but really more of a comment. There's been a lot of chatter in the chat box, rightfully so. There was a great article this past week in the Cincinnati Enquirer just about your local city council elections and school board elections, right? Obviously, I think, pediatricians have never been so involved, either in positively and negatively with school board meetings than the last several months. But, I would encourage you to, do your research on your local candidates. I know typically there's a much smaller turnout for local elections, but I think we've seen what happens when people that don't necessarily have sort of the same value for children's health and follow the same beliefs that pediatricians do. So Dan, I'm sure you maybe make a quick comment on that, but.
Yeah, the amount of outside money flowing into these races from national groups, two of the Republican U.S. Senate candidates, Jane Timken and Mike Gibbons, gave tens of thousands of dollars to several candidates that are running on kind of the anti-masks, anti-CRT platform. It's really concerning. And even like in Bexley, where we have a more progressive-minded slate of school board candidates, I mean, some of them have raised, like I think one of the candidates here has raised north of $20,000 for a school board. I mean, that's insane. That's, I do some, sort of help out some local candidates. And I mean, the amount of money, like I've never before seen targeted digital ads for school board races now Columbus Public or Cincinnati Public is a different story, but like Bexley's a small community. And I literally was on the Dispatch today reading a news article, and there were 3 different display ads for a school board candidate for Bexley. I mean, somebody's paying to that's not cheap to do. An ad buy like that is going to be a few $1,000s. And so it is really alarming. The other thing is a lot of these candidates, they're motivated by a very narrow set of issues that are also very, very contemporary. At some point in the not too distant future, we're probably not going to have kids wearing masks in school anymore. And this whole, critical race theory thing is going to blow over like Common Core did a few years ago. And then you're going to have a bunch of people on school boards that don't actually have an interest in doing the job. As somebody that's worked with local school boards and local city councils, they're very boring jobs. I mean, it's very administrative and very nuts and bolts. And when you have people that have no interest in the minutia, it's a problem. And so I think that, you sort of have 2 layers to it. You have the initial, all these people getting on school boards and causing lots of problems. But then once whatever the controversy is subsides, I think you're then going to have a lot of people that just don't care to do, we got to renegotiate our janitorial contract. We got to buy new textbooks. Do we want to partner with Apple or Dell for our computer lab? I mean, those kind of minutia that you really need people that care. And I worry that you have people that care about the wrong issues. And I'm generalizing, but I've read the article in the Inquirer. There's been some articles of the Worthington. I know Sarah Denny could talk about this. The Worthington race here in Columbus. I mean, you've got billboards going up and hate mailers going out. It's just bizarre. So that's, it really concerns me that you're seeing a lot of money flooding into these local races. It also can be a long-term a discouraging factor. I'll say it's the last thing. If you're going to run for city council in a small town, you might need $5,000, but if money keeps going up, you're going to need $20,000, and that can discourage people from running if they have to raise that much money.
So Danny, we've got time for one last question. It's related to that. Dr. Cotton was wondering, do you have a sense where's all this money coming from?
Different conservative groups. Some of it is coming from candidates like Jane Timken gave $40,000 to various school board candidates who are running on an anti-CRT platform. Just federal groups. A lot of it's conservative, not all of it, but a lot of it's conservative groups that, they're fundraising nationally. And it's going out from their path. Interestingly, though, it's not all on the right. There are some more progressive-minded groups that are putting money into school board races and council races, not nearly as much as the more conservative side. But like I said, the candidate here in Bexley that's raised like $20,000, she's very progressive. Yeah. And but it's all national groups jumping in.
I know I didn't read the article, but this morning in the lead on the digital Cincinnati Inquirer, there was something about potential infraction using Venmo. So
well, I mean, and that's interesting. Remember because I think this can't go as a thing on social media, is campaign contributions are public. If you give money, it's public. And I think somebody was mad, the parents that had Venmoed this candidate money and then were mad their name was in the paper. Well, that's a public record. You know, I would also recommend, if you run for office, do not use Venmo for campaign contributions. But you know, you want checks, you want a paper trail.
Right.
Anyways. But.
Well, Danny, thank you very much. I think so